So hello, everyone, again. I would like to introduce Dr. Maria Teresa Ferretti. She has been a postdoc at the University of Zurich Neuroscience Center and is the co-founder of the Woman Brain Project, really invested in understanding sex differences in brain health. She's currently an external lecturer at the Medical University of Vienna, and she will introduce us to sex and gender differences in Alzheimer's. I think in general, doing brain research is already very difficult as it is. Now, digging into the gender differences, it's a step forward. Thank you, Maria Teresa.
Thank you, Lavinia, for the introduction, and it's a pleasure to be here. It's a pleasure and an honor to be here. As you said, I'm the co-founder and the chief scientific officer of a nonprofit organization called Women's Brain Project. The aim of this organization, this is a nonprofit which was founded in Switzerland in 2016. And just 2 words to introduce to you this organization, which aims to understand sex and gender determinants to brain and mental health. And the way we tackle this is really 360 degrees. And you can see here in my cover slide, I put the 4 work streams that we work on, starting with basic science, which was my bread and butter at University of Zurich, so animal models, sex differences there, but also socioeconomic determinants of health, which are impacted by gender, clinical science and clinical trials. And my presentation today will mostly focus on this part. And also we will touch today on some aspects of artificial intelligence and how these sex and gender differences can have an impact in digital technologies and solutions as well. All this I would like to do in the frame of precision medicine. So the conversation about sex and gender differences in Alzheimer's and in medicine in general is, in my view, to be seen in the wider context of precision medicine. And I hope I will convince you that this is important. So first of all, a word about precision medicine, and to introduce the concept, which I think many other speakers alluded to, but I want to really focus on this in the first slide. Taking the example of breast cancer. Oncology in general is a field where precision medicine is very well established, and breast cancer in particular. I had a personal experience with breast cancer, so I can absolutely testify to all this that I'm going to tell you about. So in the case of breast cancer, when you get a diagnosis, it's not a general diagnosis, but it's a molecular diagnosis based on molecular profiling of the tumor. This allows for a precise characterization of your subtype of tumor, the expression of certain receptors, for instance, which then directs and informs the decision on treatment and surgery and drugs and whatnot. So the patients, which are a heterogeneous population, are divided into more homogeneous subgroups based on these molecular profiling, prognostic markers, also markers predictive of drug resistance or drug adverse events. And I had my own experience with this too, because in my case, the expression of 12 genetic markers was analyzed in my tumor. And based on that, it was decided whether I should do chemotherapy or not. And in my case, it was a no. So even predicting and prognostic markers of response to treatment. And my vision for Alzheimer's disease and neurology in general, and of course this is also the vision of the Women's Brain Project, is that at some point we will get to this level with Alzheimer's disease as well. So out of this heterogeneous population, we will identify subgroups based on biomarkers and molecular profiling, and these will allow us to provide everybody with a quick diagnosis and with a tailored and efficient, effective treatment. So that there is heterogeneity in Alzheimer's disease has been mentioned multiple times during this symposium. I think you're all very aware of this. I normally introduce this concept showing this spaghetti plot of cognitive decline in a non-cognitively impaired, mild cognitive impaired, and Alzheimer's disease population. And I highlight the heterogeneity that you have in the decline in the mild cognitive impairment population, where some patients even improve over 3 years and some other patients decline. Of course, a large part of this heterogeneity is driven by biomarkers, and that was also the point of this paper, but not all of it. And again, this is a common finding that people, for instance, having amyloid positivity in their brains, not all of them will go on to develop Alzheimer, cognitive decline, and so on. So there are additional factors, additional elements, and I think we need to understand those. And so the main question that we've been asking at the Women's Brain Project is basically whether some of this variability could be explained by factors such as sex. So now, before starting with the presentation talking about sex and gender differences, I propose to have a poll, and I propose a question to you, which I wonder if the poll can be launched and we can have the results live. If it's too complicated, we can skip it. But I would like to hear from you to see whether you think sex and gender are synonymous, they are the same things or not, if you're aware of a difference. I don't know, Lavinia, if this is something we can do live or we collect the
Yes,
answers.
we launched the poll right now, so people should be able to go and answer to the poll. It's the third question.
Yeah, the sex and gender question. Are they the same, synonymous? Is there a difference?
Okay. Okay, the poll has ended. Yeah, almost. There are more people. Okay. I thought.
Do we have a winner?
We do have a winner, yes.
I don't see it, so you have to tell me.
So you, basically, there is the sex and gender are not the same thing.
Exactly. So very well, you're very well prepared. This is a summary slide to explain the difference, but it looks like you already know it. When we refer to sex, we are talking about differences mostly between men and women, the simplest version, based on biology, so based on genetic expression of sexual chromosomes and the hormones that come with it. When we refer to gender, we are talking about socioeconomic and sociocultural constructs that are related to the position and the role of a woman and a man in a given society. So this is much harder to define. But it has an impact on a lot of things, including education, job attainment, pension, and so on. So the important point here that I want you to remember is that both sex and gender are determinants of health, according to the WHO. So how can they affect a disease like Alzheimer's disease? How can they affect a disease in general? There are basically, if we refer just to sex, biological sex, there are three possibilities. You can have some diseases that occur only in one sex. That's one way we can talk about biological sex in pathology. The typical example of this is prostate cancer or ovarian cancer. Those will happen only in one sex. There are a lot of diseases that occur more frequently in people of one sex, so they happen in both, but more frequently in one sex. And the typical example are neuroinflammatory conditions and inflammatory diseases like lupus, where you have over 80% of patients that are women. And finally, you have a certain number of diseases, actually quite a lot, that can happen in both men and women, sometimes with similar frequency, and yet they present differently in people of one sex. An example that is given here is stroke. In the past 20 years, we have been accumulating data indicating that the symptoms of stroke can be different in women as compared to men, as well as the response to treatment and recovery after stroke. So here I have my second poll, which relates to this slide here. So based on this definition, I was wondering, what do you think, where would you place Alzheimer? In which bin would you place Alzheimer? How does sex affect a pathology like Alzheimer according to what you know? And this would be the second poll, if we can launch it.
There is a delay in posting the poll because there was an issue with ending the poll, but it's being launched right now.
Okay.
I apologize for all these glitches, but we're getting there. So
it's okay. It's no problem. Of course, if we were live and if I could.
Okay, the poll is now there. So
yes.
If the attendees can address the question, would be great.
So based on this. Lavinia, shall we?
Okay, so now we have tight a little bit. Disease that presents itself differentially in one sex over the other, a disease that appears more frequently in one sex than the other.
Exactly, absolutely correct. So the first element is the frequency, and this is the sex difference that everybody knows about Alzheimer's, at least I hope you're all aware of it. It does present itself more frequently in women than men, in the sense that the 2/3 of patients worldwide are women, and this is a very robust finding. This is the most well-known and characterized sex difference in the field. However, to be honest with you, is not what I will be focusing on. I don't find it particularly relevant in the context of this presentation. Especially this frequency data from an epidemiological point of view, they don't really tell us much in terms of risk. And it's a very complicated, very controversial topic in the field, whether women are at higher risk of Alzheimer's based on this data. So I'm not gonna go there. I'm gonna skip altogether this part. And I will move on to the other aspect, the different presentation of the disease in men and women, which is also present. And this is exactly the aspect that we have been studying and we have been publishing on in the past years. It all started with a review I wrote for Nature Reviews Neurology. We have also published a paper that has been endorsed by the European Academy of Neurology on the sex and gender differences in the way the disease manifests itself in the context of clinical practice. And we have been positioning these differences in the context of precision medicine. So basically we're saying maybe we should pay attention whether your patient is a man or a woman, because the disease might have different features. You might want to be aware of them. And Nature has been actually endorsing our efforts in the past years, at least publishing quite a few of our letters and opinion pieces. So today, what I would like to do is to give you a little bit of an overview and a summary of some of the sex differences that have been described and are emerging in the literature in terms of disease presentation, biomarkers, and risk factors. And I would like to put all this in the context of precision medicine and give you a little bit of an idea of how I see this, the implications of these differences, which again, for us, are a gateway to precision medicine. Are a way to start thinking that the patients are not all the same and there is heterogeneity, starting with this. So starting with disease presentation, something that has been observed in several cohorts, but particularly robust in the ADNI cohort, is that women progress in terms of cognitive decline much faster than men. In the ADNI cohort, has been described over the span of 8 years that women decline twice as fast as men, which is quite a finding. And a more recent paper that looked more in detail into this ADNI data actually found that if you consider the MCI cases that are biomarker negative, there is no difference in the progression actually there is very little cognitive decline and no difference between men and women. However, when you consider biomarker positive individuals, there you have a much more noticeable cognitive decline, and these sex and gender differences emerge, indicating that there is some type of interaction between the biological sex and the specific pathology and pathological mechanisms in the brain. Something that is also emerging in the literature, and I find it extremely interesting, and I want to raise awareness on this, is the fact that the scales that are used to diagnose early cognitive impairments might not be ideal to depict early impairments in both men and women the same way. It is known that women outperform men in task of verbal memory, and most cognitive batteries used to detect early Alzheimer and MCI heavily rely on verbal memory. So there is the suspect, and there is quite a lot of literature on this topic, the idea that maybe at very early stages, especially the MCI level, women can actually mask, so they can still perform very well, not even being diagnosed with MCI, even though they have the same amount of pathology in their brains. And then they get a diagnosis only when there is an overt cognitive decline, so at a much more advanced stage. And in this paper, for instance, published again by the group of Sanderman last year, this group looked at sex-specific norms for verbal memory tests, specifically the Ray auditory test in the Mayo clinic cohort. This specific test does not have sex-specific norms, but if you were to apply them, actually you will end up with a lot more women diagnosed with MCI. So it's possible that we are missing this diagnosis of women at early stages. How about biomarkers and the actual pathology in the brains? In terms of imaging biomarkers, we start with amyloid, of course, and I have to tell you, in the literature, there is no indication of sex differences in overall amount of amyloid between men and women. Some occasional papers, but nothing robust. What is emerging, and I find an interesting line of research by Rachel Buckley and collaborators, is the fact that actually, if you consider amyloid positive individuals, and these are non-cognitively impaired individuals, and you follow them over 6 years, actually there will be a faster and more steep cognitive decline in women compared to men. So with the presence of the same biomarker, then you have a different prognosis in men and women. And this was also found at the level of tau accumulation in entorhinal cortex. So for the same amount of amyloid globally, women, which are the yellow ones, tend to accumulate more tau in the entorhinal cortex. And this result was followed up by the same authors in a more recent publication this year, where it was actually found that there are regional differences in tau accumulation, and women tend to accumulate more tau in parietal and temporal regions as compared to men. And actually, women that accumulate very high level of tau will have a steeper cognitive decline as compared to men. So there is definitely an interaction, something happening at the level of tau and an interaction with cognition. In terms of fluid biomarkers, there is a general understanding of tau differences, in particular, so not in general in cross-sectional data, but there are significant interactions between tau, sex, ApoE status, and diagnosis, so disease stage. In general, women tend to show higher levels of total tau and phosphotau, in particular phosphotau, and this differs whether you are an ApoE4 carrier or non-carrier. In the carriers, actually, this happens already in the subjective cognitive decline stage, and it kind of plateaus in the AD dementia, while in the non-carriers, it starts a little bit later at the MCI stage, and it's still observed in Alzheimer. So also differences in biomarkers. In terms of plasma biomarkers, there isn't much out there, but I just wanted to flag this paper by Vergallo et al., to which we also contributed, with actually some indication of sex differences in the level of YKL40, which is a marker, considered a marker of glial activation. And this marker was actually higher in men as compared to women in this cohort of subjective cognitive decline. So this is still something that we have to look more in detail, but always to consider. Finally, a word about risk factors in terms of prevention, which I think is a very important topic for this audience today. There is a lot of interesting sex-specific risk factors. There are quite a lot of papers about menopause and early menopause as a risk of Alzheimer. Also, robust literature on andropause as risk for cognitive decline. There is quite a lot of evidence that especially menopause involves some metabolic changes in the women's brain that might put them at higher vulnerability to amyloid deposition and tau accumulation. However, I think we are still, we don't have really a final word on this. This is a very interesting field of investigation. Same thing for hypertensive complication during pregnancy, like preeclampsia. We have to understand whether these are related to Alzheimer later on or not. There is not robust evidence on this. Pregnancies and reproductive life as well, number of pregnancies, number of abortions, and in general reproductive life elements of a woman, especially in the women, might have an impact, but this is still highly controversial. One sex-specific risk factor that I wanted to mention, because we are starting to have a bit more data on this, and I think it's potentially very interesting, is migraine. Migraine occurs predominantly overwhelmingly in women. 80% of patients are women. And there have been a couple of papers lately looking at the association between migraine and Alzheimer and dementia later on. And I'm showing you here the results from a very large UK-based study, where it was found that there was an association between migraine and development of Alzheimer's and dementia in general. However, when these data were stratified by sex, it emerged that actually there was no association in men, and the association was actually present only in the women's group. Of course, we can discuss about this data, but if something like this was true, then you would have something that is specific to a group of patients, and you might want to follow up women that suffer from migraine and target specifically this group for preventative actions to prevent development of dementia. In terms of genetic predictors, in terms of ApoE4, I already mentioned that there is an interaction with tau, and this has been shown also in a meta-analysis that I'm displaying here. There has been recently a paper that I found extremely interesting by Fan et al. That looked at GWAS data and used basically two approaches. So normally you use your GWAS data unstratified, so for the whole group of patients that you got them for. In this case, the authors actually stratified their GWAS data and developed models that were based on the GWAS on the male only and the females only. And then they checked the efficiency of these models in the males on the males and the females on the females and vice versa. And actually the sex match polygenic scores were the most efficient ones, the most predictive ones, especially this was true for hazard ratios. So a huge increase, as you can see here, the sex match outperforms significantly the sex mismatch. And this is a kind of indication that we might need to reconsider the way we look at this large data, large omics data. And we might really want to go back and maybe use such an approach where you stratify and you don't give for granted that what you find in the male population will apply to the women population. This all brings to a conversation about big data sets and the way they are used in artificial intelligence to generate predictive biomarkers. And I want to highlight here a publication that we actually just published, a paper that we just published in Nature Digital Medicine, exactly on this topic, which might be of interest to this audience. And finally, the final few slides of my talk are about the so what question, because I know at this point we have quite a bit of understanding that these sex and gender differences exist. They might be there. For us, the goal was really to raise awareness on this, and I have to say there are a lot of papers now that look specifically at these differences. So we are gaining this understanding and appreciation of heterogeneity in your data set. But then what do you do with this? Where are we going? It's still early days, but I think we should follow the example of diseases where these type of considerations have been put forward much, much earlier. For instance, stroke and cardiovascular disease. It's been, at least gender medicine basically developed in the cardiovascular field thanks to huge data sets that could be analyzed. And so now today in this field, we are starting to have guidelines for clinical treatment, for instance, and prevention of stroke that are specifically sex-specific, for instance, in women. So that could be a possibility in the future for Alzheimer's as well. Another example that I'm very passionate about is the ABIDE project, so personalized risk for clinical progression, because the whole thing in the end boils down to this individual level prediction. And the fact that when we are designing, when we are analyzing the data and using the data to build predictive algorithms for individual level prediction of risk of Alzheimer's, for instance, we might want to factor in a number of elements, and not just the biomarkers, but also modifiers of the biomarkers. And sex might be one of those, and I'm sure there are many more. So it's really just going into the direction of considering the complexity of these data sets. And for instance, in this model, in the CSF model, female gender, together with age, MMSE, A-beta, and tau, of course, were predictive of progression. So there might be really something that helps us in improving the predictivity of these models. And finally, so our conclusions is that we should move on from a model of one-size-fits-all medicine that assumes all patients are the same, because they are not, they are heterogeneous. We have now big data sets that allow us to appreciate and analyze this heterogeneity. And I think the future is precision medicine, where we appreciate the specificities of at least subgroup of patients. We can get a molecular profiling, molecular diagnosis of patients, individual level risk assessment, which allows us to do personalized prevention, individual level prognosis, which will be crucial, as well as optimized treatment and clinical trial design. So I had envisioned a third poll at this point, and I don't know if we have time to run this as well. Lavinia, you have to tell me.
Yeah, you can just posted right away, and then we have to close.
Yeah, and then we will see later. This was really my curiosity. So with this, I just want to thank you for your attention. You can follow us, and I wanted to let you know that we're actually launching a campaign for awareness on brain health, specifically targeting women that are the chief scientific officers of the families. So maybe you want to join this campaign. And I want to thank you on behalf of the Women's Brain Project team. Thank you.
So thank you, everyone, and we will discuss, there were no questions, but I have other questions, and we will discuss them in the panel discussion. Thank you.
Thank you.